do this teaching session.
Yeah, no problem at all. That I can do one of two things. I'm happy to just be guided by you guys. We can either just be sort of interactive and do a couple of discussions and answer any questions anyone has about thyroids, and we can have a bit of a discussion that way, or I can do a presentation for you, which I've got on thyroid assessment of thyroid nodules.
I think what we can do a quick presentation, and then maybe we can discuss a case, all of us, after we have like the big knowledge, and then
okay.
Yeah.
Fine, let's do that then. So I need to, I absolutely hate Teams. I think it's horrendous. I can never get it to work, unlike Zoom, which I seem to manage all right. Now, does anyone know how I share my screen?
Hi, Mr. Hobson. I'm Haytham from MRI. Thank you so much for attending.
How are you doing? Nice to see you.
We are recording this beautiful meeting, so you will find like 3 dots on the right side beside the red phone. Just click on it and then start sharing, screen share. Look for the 3 dots at the bottom of the screen.
Oh yeah. Switch camera. Yeah. I've got a share presenter mode.
That's it. Yeah, that's the one.
Yeah, but then you're not seeing. Are you seeing my computer? Seeing my presentation?
No, not you. Can't you see you?
Should be a share tray. Do you know where? This one. Yeah. Share content. That just looks like slides. Can you see that at all?
No, we're still seeing you, but not your slide, not your computer.
Khalil, are you on a computer?
Right, I tell you what, let's just forget about that because it's boring and it's really not a great presentation.
I was just going to say you can forward it to Khalil.
What I'm going to do is I'm going to talk to you and you can talk back to me like we used to do in the olden days, and we can try and work out how we'll manage a few patients. So, 34-year-old barrister and keen choral singer finds a lump in her neck soon after becoming pregnant with IVF. So, firstly, is this a real patient or a made-up patient with all the little tick boxes for problems? What does everyone think?
Certainly a made-up patient. There's a lot of key points and stuff. So,
yeah, there are, aren't there? So it's like one of those, you know, in the old days, if an exam question said you meet a sailor, the answer was always syphilis, seemingly, because they had, you know, a habit of acquiring various disorders in ports of call. This is actually a very good mate of mine, who, this is a bit of an older story from about 10 years ago. She's more like 44 now. But yeah, it's a friend of mine who's a barrister and is a very good singer and had a lump in her neck soon after becoming pregnant. So I thought it was quite a good sort of a good case to discuss because it as you say, it's got all of the risk factors and problems of thyroid surgery. So how would okay, so what are you going to do? She's patient in clinic. What do you do in terms of taking history?
So for me, if I'm going to assess this lady, I will go with the history taking about when did this lump started and how progressive it is in the size of it.
Okay.
What is the cause of the disease? Is there any pain associated?
Okay.
Is there any family history in her first-degree relatives? Any autoimmune disease in her?
If there was pain with this, what would pain be suggestive of?
I would think of thyroiditis.
Yeah, absolutely. Like, and who does thyroiditis happen in?
Yeah, it could be. If we, this will guide us
who does it happen in? Who gets thyroiditis? I mean, obviously anyone can get thyroiditis, but anything in the history that makes us susceptible to thyroiditis?
Just got pregnant.
Yeah, exactly. You often see pregnancy. You obviously thyroiditis in pregnancy or postpartum thyroiditis. So that's a sort of risk factor for thyroiditis. So yeah, absolutely. So if you think if this pain's unusual, I mean, most neck lumps present painlessly, and therein lies one of the problems about late presentations of neck cancers or head and neck cancers or thyroid disease, because often, if you've got a painless lump, quite often you won't notice it. In fact, I saw at least half a dozen patients during lockdown who had lumps in their neck that were only discovered by relatives when they were on, Zoom calls, and it was like, oh, there's a lump in your neck. Oh, I've never noticed it. And if something's not painful, you're less likely to realise that there's a problem there. So yeah, absolutely, that's good. Any of the muted camera off people? Any other suggestions for as part of the history? Anything else you'd want to do? Or you can. Is there a chat bar? I don't even know if there's a chat bar here, really. Can't find a chat bar.
You can ask about the IVF.
Yeah. What would you like to know about the IVF?
I guess when she started it, has she done it before? Any issues, etc.
Yeah. Why do more women get thyroid disorders than males?
Is it because the hormones, you mean? Like having menstruation or hormonal disturbance would affect the TSH, is it?
Yeah, absolutely. So there are homologies, I think that's the word, homologies or homologs between thyroid stimulating hormone and female reproductive hormone. So basically, female reproductive hormones are like a sort of constant low level of TSH effectively. So yeah, absolutely. Yeah, so you want to know about the IVF. Anything else?
Being a singer, I think this will help in decision making, but not in management, I think, unless if we are talking about surgery versus medical treatment. But we don't know yet which type of.
So what is the when you consent patients, what is the does anyone know the legal footing against which we consent patients these days, or what legal judgments we look at in terms of consenting patients?
We should be documenting the vocal cord mobility pre-op as well. In order to know if both sides are mobile pre-op, if we're suspecting something, as if there will be a claim or something post-operatively. At least being a singer, this means that she would have some good mobile cords, but just documenting the mobility of the cords is something important for her professional voice.
So you're right, documentation of core mobility is important, but in terms of the consent process, do you know what we should tell patients about risks and benefits in terms of consent?
Do you mean for the percentage of recurrent laryngeal nerve injury, hypocalcemia, REI? Is that what you mean, or?
Yeah, so in 2015 there was a court case. I don't know if anyone's familiar with this or is aware of this, but it's called Montgomery versus Lanarkshire. Has anyone heard of that? So there's a lady called Nadine Montgomery who had diabetes, and she was small. So if you're diabetic, you're likely to have a big baby, and she ended up having a vaginal delivery, but he had this condition called shoulder dystocia, which resulted in hypoxic injury and cerebral palsy. Now, her obstetrician hadn't said to her that there was an increased risk of complication from vaginal deliveries, and hadn't offered her a caesarean section. And she sued for negligence, and she'd argued that had she known there was an increased risk of shoulder dystocia and hypoxia, etc., she would have requested a caesarean section. And the argument from the obstetrician was, if we offer people caesarean sections, everyone will want one. Now, to me, seems like a good argument for doubling the size of your service. If you offer something, if you build it, they will come. But anyway, for whatever reason, she wasn't offered a caesarean section. And this went all the way up to the Supreme Court. And the bottom line from a very long legal judgment, and I'm just reading this out here, is it's established that rather than being a matter for clinical judgment to be assessed by professional medical opinion, a patient should be told whatever they want to know, not what the doctor thinks that they should be told. Now, that's a very, very sort of vague legal interpretation of a very sort of verbose and dense legal judgment. But the bottom line is your consent process, and I'm sure we all do this because we've moved on since 2015, which, bearing in mind, is nearly 10 years ago, should move from, you know, I've discussed a 10% risk of this, a 1% risk of that, a 2% risk of that, to matters which are pertinent to the patient in front of you. Now, of course, how do you know what's pertinent to the patient in front of you? Only the patient in front of you knows what is important to them. But absolutely, if someone is a singer, then you need to discuss in much greater detail the risks of voice change post to either the superior laryngeal nerve or recurrent laryngeal nerve after surgery. Similarly, if someone is, for example, a chef or a sommelier, or has a job that involves sniffing and sensing things, you know, arguably the consent process with regards to a septoplasty, where there is a small, albeit very sort of fairly negligible risk of anosmia, is much greater than it would be for someone who doesn't have a role that involves that. So yeah, the fact that she's a singer is important, but it's not the be all and end all. And of course, if you've got someone who you think might have cancer, then you're going to go ahead and operate regardless. Okay, so anyone know, in patients with all comers, patients with thyroid nodules, what percentage have got malignant cells?
That's a difficult one.
Yeah. Quite, it's lower than you might think. It's about 10%. I don't really know how a study like that gets an answer like that, because of course not everybody who has a nodule will go on to have an FNA. But this is one of those sort of case control, case studies looking at all comers with nodules, be they benign or malignant. So the majority of thyroid nodules are benign, and of course we get that because the majority of thyroid nodules come back as U2. But if you've got thyroid nodules, then you're duty bound to investigate them. So what's the mainstay of treatment for thyroid nodules? So how do we investigate this lady?
Do you start with an ultrasound?
Yeah.
And then a biopsy?
Yeah.
Yeah.
So, the right answer, I suppose, is always take a history, which we've done, do an examination, which we do. You look for signs of hyper or hypothyroidism. I must admit, I don't think I've ever picked up clinical signs of hypo or hyperthyroidism, primarily because these patients usually present to you with painless neck lumps, but they're clinically euthyroid, or they come across from the GPs or the endocrine team having been treated for hypo or hyperthyroidism, and by the time that you see them, they are biochemically euthyroid. So yeah, you do an ultrasound. So Hytham, who does ultrasounds? Do you do ultrasounds where you are up at the MRI?
Informally in clinic, yes, but I would ask for a professional ultrasound after we just have a look about the U classification, if it is 1 to 5, and offering FNA. We have a cytologist here on site, actually, who are really helpful in addressing which nodule are we going for. But asking for TFTs is quite important as well, because we wouldn't FNA a hot nodule or a hyperthyroid, which will give us like false positive cells. Let us think of something like as a diagnostic unnecessary surgery. So yeah, in clinic, history taking, examining the lump, if I can feel it, how big it is, which side, is it going retrosternal, and then offering an ultrasound if I can, TFTs on site, and then ultrasound guided FNA will be the first step in going towards a cold nodule, if we can say that. With the U classification, it will help in balancing the decision with the Thai classification of FNAs, I think.
Yeah. Yeah, absolutely. So there's a U classification, U1, 2, 3, 4, 5. What's a U1 nodule, or what's a U1 diagnosis?
Normal thyroid tissue, I think.
Normal thyroid with no nodules, basically. And how often do we get U1 thyroids?
On an ultrasound, I don't know the percentage, to be honest, but if it is a U, I haven't seen it much. U2 is commoner because we can't see a nodule and feel it. But...
Yeah, so it's a bit of a trick question, really. Basically, we don't tend to ultrasound people unless there's a reason to ultrasound them, either because you can detect a nodule clinically or they have a nodule picked up on MRI or CT. And so most patients who have a thyroid ultrasound have something there. So I don't think I've ever seen a U1 thyroid nodule, because you're not going to be ultrasounding something that isn't there. So a bit of a trick question. So U2, 3, 4 and 5, I often say to patients, are increasing sort of grades of, or sorry, U2 is a benign nodule. U3, 4 and 5 is increasing grades of concern. So a U5 nodule is almost diagnosable as a cancer on ultrasound, whereas U3 is a bit borderline. And the way I think it's quite useful to use analogies when I'm talking to patients. And anyone who's been in clinic with me has probably heard me ranting on about all sorts of weird things, like sort of gaffer taping pieces of fruit to your neck and all that sort of stuff. But I think analogy is quite a useful way of trying to put things into context for patients. And what I normally say is, you can look at your arm and you can look at your skin and know it's normal skin, and you can look at a freckle and a freckle is just a freckle, nothing to be concerned or worried about. You're going to have something that's black and bleeding and irregular in size, and you don't need to spend too many hours thinking about it on the tanning lounge or tanning bed to realize that you might have something that shouldn't be there. And that's sort of the equivalent of a U5 nodule. Or you can have a mole, and everyone knows what a mole on the skin is. And what I often say to patients is, a U3 thyroid ultrasound is a little bit like a mole. It's not completely normal, but nor is there anything that we're massively worried about, but we probably need to investigate it a little bit further. And I just find that a useful way of describing to patients what it is I'm concerned about. So somebody who is off screen, what are the ultrasound features of a benign thyroid nodule, a U2 nodule?
The chat box, someone is saying
using RAM, say, in hypo.
Oh, I've got the chat. Yeah. Okay. Yeah. Perfect. Yeah, that's good. So spongy form, looks like a sponge. Cystic, hypoechoic. Hypoechoic means a light-coloured grey. Egg-shaped calcification, peripheral vascularity, and something that they called an echopore halo, which I think is the equivalent, Martin, of what you said of an acoustic shadow. And then, okay, any takers for malignant nodules? Lobulated, yeah, absolutely.
Solid.
As well, sorry.
Solid, taller than wide.
Solid, yeah. Solid is more likely to be malignant than cystic. Hyperechoic foci, so it looks blacker, basically. A regular margin. Internal vascularity, absolutely. And they have this concept, and I've no idea why this is the case. It makes absolutely no sense to me whatsoever, but it's a pretty decent specifying feature. if it's so-called taller than wide, in other words, if the AP dimensions are greater than the anterior-posterior dimensions are greater than the coronal dimensions, that's said to be a marker for malignancy. Goodness knows why a tumour should grow in this axis, the x-axis, rather than the y-axis, but by all accounts, it's a good marker of malignancy. Okay, so which of these are we going to stick a needle in? Okay, U1 nodule. Who would stick a needle in a U1 nodule?
No one.
No, there's nothing to stick a needle into, is there? It's just normal thyroid. Okay, that's good. U5 nodule. Who would stick a needle into U5? Kind of assuming everyone would.
Yeah.
Yeah. U4, everyone?
U3.
Yeah.
Someone said the U3 and above.
U3 and above. Yeah, absolutely. I definitely agree with that. U3 and above, you are mandated to do a fine needle aspiration. And if you're ultrasounding them, then you're able to do it at the time. Slightly irritating that, I'm sure you're the same on the MRI side. We often get patients who had an ultrasound scan performed, often by a sonographer, and it will then say U3 nodule, advise ultrasound guide, advise referral to ENT, and for ultrasound guided FNA. And the problem is that sonographers aren't able to do FNAs, and sometimes they have a time slot. Obviously, it takes a bit longer to do an FNA, so they have a time slot to do a diagnostic scan only, and so the patient has to then come back to have the needle test done. But yeah, U3 and above, you're mandated to do an FNA. What about U2? Who would do a U2? Who would do an FNA for a U2 nodule?
Yeah, we shouldn't be FNA any U2 or a hyperthyroid one. Can I ask about a U3 less than 1 centimeter? Should we FNA it?
In this country, the British Thyroid Association guidelines don't distinguish in terms of size. In the US and in Europe, they do. So in the US, they tend not to FNA less than sub-centimeter nodules. Having said that, we've all come across patients who have sub-centimeter nodules that are malignant. So yeah, the guidelines are that you should do. You're absolutely right. The guidelines are suggested that if you have a U2 nodule, then you shouldn't be FNAing those. There are two slight sort of criteria for that. The first is, to a large extent, if there's patient concern, often the ultrasonographers will do an FNA after discussing it with the patient. But also, as we'll come on to with a Thy3A nodule, Thy3A nodules should probably be FNA'd on 2 occasions before discharging a patient and saying it's absolutely fine. And so, U3 nodules, I'm getting confused. U3 nodules which come back as Thy2 should be subject to 2 occasions, so they'll often be FNA'd twice. But generally speaking, yeah, you're right. A U2 nodule should just be reassured and discharged. Okay, so is everyone happy with ultrasonography?
Yes.
Yeah, good. Okay, so we then get back our results: Thy 1, 2, 3, 4, and 5. What does Thy 1 mean?
Said non-diagnostic. Ram said that.
Yeah, Thy 1 absolutely is non-diagnostic, and that can be because you've got blood. You've got, quite often you'll get a cytology report that says there are follicular cells with this sort of nuclei, this, that, or the other, these features, and then the bottom line says, but I cannot make a diagnosis on it, which is quite frustrating because you've obviously got some specimens. But often it's described as non-diagnostic. The malignancy rate of Thy 1 nodules is said to be up to 10%. And I think that's just because you cannot exclude malignant disease because you don't have enough tissue to make it, or enough cellular sample to make a diagnosis one way or another. So Thy 1 FNAs are described as non-diagnostic. I think they can be a helpful result in a patient who, you know, perhaps has a U3 nodule, who doesn't want to have surgery, who's had a couple of Thy1s. They're not diagnostic, but you can equally turn around to the patient and say, but on the other hand, we haven't seen any malignant cells. So sometimes a Thy1 can be useful in terms of decision making, but generally speaking, they're non-diagnostic and should be repeated. The problem is, how often do you repeat them? And the BTA guidelines suggest that if you've had, you know, more than 2 Thy1 FNAs, you should potentially proceed to diagnostic thyroid surgery, which, you know, in the context of someone who's had, for example, an FNA of a U3 or a U2 nodule, or, you know, a needle test of, as you were saying, Hytham, you know, if you had a sub-centimeter U3 nodule that comes back as Thy1 on 2 occasions, do you particularly want to subject the patient to a hemithyroidectomy? But that's certainly what the guidelines currently suggest. So Thy2 is the one that we like. Thy2 is benign disease.
Yeah.
And what's the risk of cancer of a Thy2 nodule? Anyone want to put a number in the chat box? Yeah, it's not. You'd think, Alex, it's less than 1%. It's actually said to be between about 0 to 3% on various studies, which does seem a little bit high to me. Yeah, 3%. Well, yeah, Ram, well done. That's that. Yeah, 0 to 3%. Did you type that just as I'd said it, or did you type it and press send just the minute before it came out of my mouth? But you've got a slow dial up. We're just in sync. Very good. And then Thy3. Obviously, Thy3 and Thy3 is divided into Thy3A or Thy3F. So Thy3 with cellular atypia or follicular neoplasm rather. So what are the quoted malignancy rates for a Thy3A nodule?
15%, yeah.
What's the range?
Yeah, 5 to 15, someone on the
15, yeah, 5 to 15, I think.
5 to 15. Okay. What's the range of malignancy for a Thy3F nodule?
Yeah, Amr said 15 to 30.
15 to 30. Okay. And that's obviously quoted, and that's dependent on cytology in the institute in which you work. Now, this is a Wythenshawe-based statistic, so it will be different to MRI, because obviously Wythenshawe cytology is performed by different cytopathologists to MRI cytopathology. But the malignancy rate of Thy3A nodules at Wythenshawe was 25%. And the malignancy rate of Thy3F nodules at Wythenshawe was, anyone hazard a guess?
Probably going to be more than 30%.
25%. So
Oh.
we did an audit a couple of years ago. This was probably looking at thyroid FNAs from, I'm going to say, 2010 to 2015. And 25 is just a sort of hold it in the air number. It was something between 24 and 27% for Thy3As and Thy3Fs. It was almost identical. So I don't particularly pay a lot of credence between a Thy3A and a Thy3F. I know there are quite a few people who, if you've got a very you know, if there's no suspicious features on the ultrasound with a Thy3A, won't necessarily do anything. But I'm always a bit wary of Thy3As. I have to say, in my own experience, I find that the malignancy rates with Thy3As are, you know, sometimes are often as high, if not higher, than the Thy3F. So I tend to recommend for Thy3F, I will always go straight to diagnostic hemithyroidectomy. For a Thy3A, I will usually repeat the FNA, and the FNA comes back as Thy3A again, I will proceed to diagnostic hemithyroidectomy. If it comes back as anything higher than a Thy3A, obviously that takes the decision out of your hands. If it comes back as non-diagnostic, I'll have a discussion with the patient, and it's really only the ones that come back as benign the second time round that I'll discharge. Of course, the problem with a second FNA is you can't unknow the answer, the result of the first FNA. So just because someone's got a benign FNA on the second attempt, that doesn't negate the Thy3A cytology that they had initially. Okay, so we've got our U classification and we've got our Thigh classification. So non-diagnostic, we will repeat. Thigh2, we will either, if it's a U3, you should repeat it, but often with a Thigh2, you'll usually just discharge. Thigh3A, you'll often repeat or go straight to surgery. Thigh3F, you'll usually go straight to surgery. And then similarly, Thigh3-4, what's the malignancy rate of a Thigh4 FNA? 70%, very good. And what about for Thigh5? Anyone putting a number in? 100%. Yeah, I wouldn't ever put 100% in. 100% is yeah, I like that. 97. I would go between, no, tell me you're a bit low. It's a bit like, does anyone know Bruce Forsyth, play cards right? Higher, lower, higher, lower. I would go for 97 to 98%. More often than not, it is 100%, but 100% is quite a, you know, it's a degree of certainty that we don't always get in medicine, and particularly don't always get in medicine from cytology. So yeah, anything between 97 and 100% for Thigh5. Okay, so we've got our patient. They've come back with a Thigh3F or Thigh4, and we're going to take them to surgery. So what operation are we going to do for someone? Let's say they've got a 2 centimeter U3 Thigh3F nodule on the left side. What operation are we going to do?
Are you going to do a left hemi?
Yeah.
Diagnostic left hemi.
Yeah, probably. Any other options?
Lobectomy?
Well, hemi and a lobectomy are effectively the same thing.
You mean total mastectomy?
Would anyone do a total thyroidectomy?
In a Thigh3F?
You could do.
So if someone, okay, so here's the thing. If someone had a 4 centimeter Thigh5 nodule, what would you do?
Do a total.
I think so. Okay, so if you've got 4 centimeter Thigh5 nodule, you probably do a total. My experience with Thigh5 nodules is they're usually quite small. I've no idea why, but the majority of Thigh5 nodules I come across are usually about 1 to 2 centimeters. And so what's the treatment for a well-differentiated thyroid cancer of 1 centimeter or less? So forget about medullary cancers and forget about anaplastics, but for papillary or follicular thyroid cancer, so well-differentiated thyroid cancer, if it's 1 centimeter or less, treatment, a hemithyroidectomy is sufficient treatment. If it's 4 centimeters or greater, or there are concerning features such as hernal cell malignancy or tall cell malignancy, or the subtype of malignancy, or there's lymphovascular invasion, the treatment is ultimately a total thyroidectomy with radioactive iodine, which means if you've done a hemithyroidectomy on its own, you have to come back to do a completion thyroidectomy and then give them radioactive iodine. But the treatment for tumours that are 1 to 4 centimeters is personalised decision making. So it's a discussion with the patient. So obviously, if you've got a tumour that's 1.2 centimeters, you're probably going to err closer to the side of a hemithyroidectomy being sufficient than if you've got a tumour that's 39 millimeters, for example. But effectively, for nearly all of those patients, in the with a Thy3 and above, you would probably offer them a hemithyroidectomy alone, unless they're the Thy5 group. The two provisos for that would be unless they're the Thy5 group of patients who've got a sort of 3 centimetre tumour or greater, or there are nodules on the contralateral lobe, or evidence of compressive symptoms for which you're going to take the whole thyroid out. But for the majority of patients with nodules, they end up having a diagnostic ipsilateral hemithyroidectomy. Yeah, absolutely. So what have we covered?
A question.
Yeah.
This is interesting because if we're talking about a small Thy5, like a 1 to 2, we are still considering. I know this is a personalized decision, and in the guidelines, do we have something to let us do a hemi in a small one still, or are we still into more studies to help in including the size of the nodule, even if it is Thy5 for a hemi?
So I think for a small Thy5, so in Manchester, we don't discuss any preoperative patients in the thyroid MDT. They're all protocol driven. So in some units, everybody who's got a 3A and above gets discussed at the MDT, but the numbers are such that it becomes impractical to do that. So we will discuss, so if someone's got a Thy3 AF or a Thy4 FNA preoperatively, we will proceed to a diagnostic hemithyroidectomy. Certainly for a Thy4 patient, 30% of those patients don't have cancer. So to take the entirety of the thyroid out, means that 3 patients in 100, you condemn them to a, lifetime of needing to have thyroid replacement, plus or minus calcium replacement, plus you increase the risk of voice change and the need for a tracheostomy. So it's only the Thy5s really where we would make a decision to go for a total in the first instance. And we will always discuss these patients in the thyroid. The Thy5s we'll always discuss in the thyroid MDT. And the general consensus is, depending on the size, if it's sort of 3 centimeters and greater, we'll usually err towards total thyroidectomy. 2 centimeters or less, we're usually towards a hemi. But again, with patient decision making, so some patients will say, I just want one operation, I'll have the whole thing out. Others will say, I just want to have a hemithyroidectomy and see where we get to after that. But yes, you're absolutely right, and you've kind of preempted the next bit of what I was going to say, which, because I can't share my slides, I'll just talk through very quickly. But is anyone aware, or does anyone know of any tumor suppression genes or oncogenes that are seen in thyroid cancer? Can repeat the question. Is anyone aware of any oncogenes or tumor suppressor genes which are seen in thyroid cancers?
What I know is the RET, RET and medullary.
Yeah. RET is seen, is frequently seen in papillary thyroid cancers. And the other ones are BRAF, BRAF, RAS, RAS, and TERT, TERT. And effectively, so RAS is a protein which is a small GTPase, which turns on cell growth. BRAF is responsible for cell signaling. TERT, T-E-R-T, adds telomeres to chromosomes. As chromosomes divide, they get longer and longer and longer, and the long ones get sort of chomped away. So TERT adds telomeres to chromosomes to prevent apoptosis of those cells, and P53 is a tumor suppressor gene. And so if, for example, you've got a sporadic papillary thyroid cancer that's just arisen, you don't have any of those mutations, your recurrence-free survival at 15 years is going to be about 95%. If you've got a TERT mutation, it's going to be about 80%. If you've got a BRAF mutation, it's going to be about 70%. And if you've got BRAF and TERT mutations, the survival rate at 12 years is virtually zero. So not all papillary thyroid cancers are the same, and aggressive tumours have TERT mutations, and highly aggressive tumours have TERT and BRAF mutations. So why is this important? And this comes back kind of to your question about what we do with Thy5s, but also probably more importantly, it comes down to what we do with the Thy3A patients, where we're not sure whether we should be operating or not, or indeed the Thy3F patients, where we know that 70% of patients, are not going to have malignancy. And so I am only aware in this country of one unit that does sort of genetic analysis on thyroid cancers, and that's Neil Tolley down at the Hammersmith Hospital. It's used quite a lot in America, but it's pretty expensive. And what you can do is, just like you can do an FNA and you can send cells off for cytology, but you can also send them off for immunotyping. What you do is you basically identify mRNA fragments within the FNA. And so you identify whether these cells are producing one of these proteins, be it a tumor suppressor or an oncogenic protein. And it's an absolute game changer. And I think it's something that we will do in the UK at some stage, but we're just not doing it at the moment. And so if you've got there's one called ThyroSeq, ThyroSeq, and it looks for a whole variety of gene mutations, BRAF, TET, there's a whole heap of other ones as well. And basically, in someone who's got what they call in America FLUS, FLUS, their equivalent of Thy3F is FLUS, and their equivalent of Thy3A is AUS, AUS, but it's effectively the same. So if you've got a FLUS or a Thy3F in America, if it's negative on the ThyroSeq genetic tests, the cancer risk is about 3%. But if it's positive, in other words, if they've got gene mutations, then even a Thy3F, the cancer risk goes up to about 75 to 100%. And so gene sequencing is a way of not just looking at the cells cytologically speaking, but analyzing those cells to see what proteins they produce, and if they are producing oncogenes and not producing tumor suppressor, or there's mutation of the tumor suppressor genes, then they're much more likely to be malignant, which will drive and guide our decision making in terms of whether to go for a total thyroidectomy, or indeed for the Thy3A or Thy3F FNAs, whether we can just leave these patients alone. And as I say, the ones to remember that, the sort of take-home message is P53 and RAS oncogenes are important, but if patients have got BRAF and TERT together, then the risk of malignancy and aggressive disease is extremely high. And so BRAF, yeah, P53 is in there. Sorry, I haven't seen the chat bar. So that's basically I've sort of gone through the last bit. I've just gone through some of the slides that I was going to present, but I've just done those verbally rather than, as I still can't work out how to share my screen. But that's basically my sort of short talk on how to work up thyroid nodules. I was just going to do thyroid today and leave parathyroid for another time, because parathyroid is a sort of a topic in and of itself. It's another big thing to talk about. But we've covered a few things. We've covered sort of assessment, we've covered ultrasonography, we've covered cytology, and then we've covered genetic sequencing and sort of the future of thyroid diagnostics. Does anyone have any questions or any case studies? Or I think sometimes it can take your I personally think the workup of thyroid disease is exceedingly straightforward and exceedingly simple. But I think it can sometimes take you a while to get around why you do the things that you do. particularly with 3As and 3Fs, and who has a hemi and who has a total. But does anyone have any questions, or does anyone have any sort of, well, I saw this happen and I'm not sure why that occurred sort of scenario?
Thanks, Mr. Hobson. I just have a question about cysts. Would you just observe or aspirate and inject ethanol? Because it's quite personalized decision as well.
Yeah, so in the UK, again, in Europe, they're quite keen on either doing radiofrequency ablation of cysts or ethanol injections into cysts. We don't tend to do that much in the UK. Generally speaking, cysts, if you're happy that they're benign, you can aspirate them. The problem with aspiration is more often than not, they will come back. And so the general management of cystic thyroid disease in the UK is generally to offer surgery to remove the cyst if the patient has compressive symptoms from them. They can absolutely be observed, and if they're less than 4 centimeters, there's not necessarily any rationale or reason to intervene or to either aspirate or operate on them. But in the UK, certainly we tend to remove them surgically.
And another question, please. It's a little bit advanced, but when would you decide to dissect lateral necks with level 6 as well? Is it something you decide in an MDT or intra-op?
Yeah, no, we would definitely. I mean, well, firstly, a level 6 neck dissection is you can think of it to an extent as like an extended thyroidectomy, because it's right where you're doing the thyroid operation. So I think it's feasible if you see nodal disease in the central compartment when you're doing a thyroid operation, because you're there to take it out. Lateral neck disease, if you're going to operate on that will involve a neck dissection, which is a totally different operation. So you shouldn't be doing that prior to a decision to operate. Lateral neck disease from thyroid cancers is it's not that common. I mean, there are patients do undergo it, but the majority of patients don't have, quite sizable thyroid cancers don't have metastatic neck disease. And this should all be highlighted on the preoperative ultrasound. Again, generally speaking, we won't do, apart from medullary thyroid cancer, which is a slightly different sort of subspecialty, the well-differentiated thyroid cancers, we won't do lateral neck disease unless there is evidence of metastasis. We don't do a prophylactic or preventative lateral neck dissection. So we'll only do it if there is evidence of cancer in the lateral neck. Again, the way we treat thyroid disease in the UK and Europe is slightly different, and certainly in France and in Italy and Greece, the de facto treatment seems to be central neck dissections for most patients. The problem with doing central neck dissections is that because the prognosis for thyroid cancer is so good, it doesn't seem to offer a massively significant survival benefit. But there is a much higher risk of voice change and hypocalcemia. So in the UK, we tend not to do a central neck dissection unless there is preoperative ultrasonographic evidence of level 6 nodes, or, as I've said, if you notice them intraoperatively, I don't think it's unreasonable to proceed with the neck dissection. The patient already being consented to a risk to their vocal cords, or the voice rather, and hypocalcemia, to proceed at the time of surgery.
Thank you. And is using the nerve monitor, is it medical legal in UK still, or as for the pressure nerve, or can we still operate without it? We are about to have one here, but I'm just asking, would it help? I know that it wouldn't make a difference.
I mean, there are very few people who don't use a nerve monitor. It's not defined as standard of care by any guidelines or bodies, but the majority of surgeons in this country anyway will use a nerve monitor. I think if your department doesn't have a nerve monitor, that's obviously you don't have it. You don't have it. If you've always operated without one and you've got good results and you're part of a national audit, I think that's a reasonable thing to do. I think the very difficult call is if your department has a nerve monitor and you choose not to use it, and the patient has nerve injury, I don't really see how you can come up with a reason, with a good defense for that. So, but the bottom line is, no, it's not negligent to not use a nerve monitor. But I think it's hard if a patient has a nerve injury and you have access to a nerve monitor to explain or defend why you have chosen not to use it.
I agree.
Right, brilliant. Was everyone happy?
Yeah,
Thyroids in a nutshell.
yeah, that was great, Mr. Hobson. Does anyone have any questions? You can drop it in the chat before we finish.
My pleasure.
Okay.
Yeah, ethanol does seem to have a good prognosis. I think it's the reason we don't do it, I think, is because it needs to be done, generally speaking, under ultrasound guidance. And for lots of units, I know the MRI is a bit different to us, but a lot of units, the ultrasound is done by the radiologists. And so if you're going to set up a ablation service, you probably need a radiologist who's keen to do it. And most radiologists are drowning in diagnostic ultrasonography requests, so are not particularly interested in setting one up. I think that's probably the rationale. Again, it's one of these things in America. If you buy a new machine, you can set up a new service and charge for it. So why wouldn't you do it? Whereas in the UK, with the majority of patients being treated in the NHS, getting a new service up and running is like wading through treacle, and then you've got to find the time to do it and set it up and all the rest of it. So we all end up doing what we're sort of incentivized to do, I suppose, ultimately. But yeah, watch this space.
Okay, great. So one last thing, Mr. Hobson, because we want this teaching to be able to generate ideas for research and audience quality improvements, etc. What do you think is a good idea to work on, maybe even regionally across MRI and vision show for research in this area, or any quality improvement that might bring a change?
So I don't know so much about quality improvement, but the two things I think are worth auditing on a repeat basis, and I've done this in Wythenshawe, but I think it would be useful to look at across the Northwest. The two things I've mentioned earlier on is to look at the malignancy rate of Thy3A and Thy3F nodules, because I do think it differs from the published data. And the other thing, I think we probably get fewer Thy5 cytology FNAs at Wythenshawe than you do at the MRI, because I think our cytologists have previously been reluctant to call it as a Thy5. But I think it would be, just out of interest, in my observation previously was that Thy5 nodules tend to be small. I think it would be good to look at the size and dimensions of Thy5 nodules, because from my experience, the majority of them do seem to be quite small. I don't know why that is, but those are the two things that I would audit and look at. They're not particularly groundbreaking in any way, shape, or form, but I think they're very easy to find out, and I think they come up with some quite nice data, and I think they're both quite presentable. So those are the two sort of, if anyone was looking for a sort of 2 to 3 month research project to do, those are the two that I would probably recommend.
Thank you, Mr. Hobson. I think this is a very good idea. If we agreed, even like within Northwest or Central Manchester, in order to just look into the rates of our Thy3s and Thy5, at least we will have a good number to chase these patients onwards, to check what are our numbers compared to the national ones, and look into this would help them.
And certainly just looking across, you can do it in the Northwest, but looking across MFT alone, it's generally quite straightforward to speak to the pathologists from their database to get a list of all the patients with that cytology. And then using Hive, it's dead easy to get the details of what surgery they had and what the outcome was. So it's quite strict. It's not you know, I think there are lots of consultants, my experience as a trainee, there'd be consultants saying, oh, do this, it's amazing, it'll be great for you. And you end up on this wild goose chase, chasing data for years on end and nothing comes of it. But I think, you know, the ability to get the information you want is a lot easier now with EPRs. Okay, well, look, I'm sorry I couldn't get my my screen share to work, but I think it's probably better to do. I think most people just sort of fall asleep in a presentation, so I think it's probably better to have something that's slightly more interactive. I hope everyone has a lovely afternoon.
Oh, sorry, are you able to send a slide? Are you able to send the slides to us, or is that possible?
Yeah. Who's coordinating? This is Khalil, isn't it? Who's coordinating it?
Khalil, yeah.
Yeah, I will send them off to Khalil. I need to just change them to the right
PDF
format because they're in they're in Mac format, which presumably not everyone will be able to access. Yeah, I'll send them across to Khalil.
Okay, thank you.
All right, no worries. Thanks very much.
And see you in the next lecture for thyroid.